Dr. Brian Quinn, thank you so much for joining us here on the Science of Psychotherapy podcast. Great to have you.
Thank you so much for inviting me on. Very much appreciate it.
And Richard here, Brian. It's so good to have you able to speak to you. But we had that wonderful interview you did with Roger Kaiserstein in the magazine, and we were really grateful for that. And we just wanted to get in a bit more with you because it's so interesting, the work you do.
Sure.
Now, for those who don't know you, maybe a little bit of an introduction. Can you give us a bit of your background?
Yeah, so I'm a clinical social worker in New York, and I've been doing psychotherapy for 40 to 45 years. And I got interested in this topic when antidepressants began to be prescribed extensively in the early 1990s. And I began to find that a lot of my patients on antidepressants weren't doing terribly well, or they were actually getting worse. Started to do some research, and I found, one of the main reasons is if the people have bipolar depression versus plain depression, they're just not going to do well on antidepressants. And that's the current science. That's not Brian Quinn's idea. That's where the current science is at.
Yeah, now I'm wondering if you could tease that out a little bit, because that was something very new to me and no doubt new to a lot of our listeners about the fact that these antidepressants, which are prescribed quite frequently for depression with bipolar, is not the way to go.
Right. There's a couple of layers of this problem. One is that most prescribers, including psychiatrists, will prescribe an antidepressant for anyone with symptoms of depression. And this is a big mistake because depression is not a diagnosis, and when you think about it. It's a collection of symptoms with many possible causes. And one of the many causes is bipolar illness. People often forget that bipolar illness is a predominantly depressive illness. And the mistake prescribers make is to go from symptoms of depression to diagnosis of depression to treatment with an antidepressant, rather than keep in mind the differential diagnosis. They're depressed, but what is that a symptom of? It's kind of like if you go to your doctor with a cough and a fever. He doesn't diagnose you with a cough and a fever disorder. He tries to figure out what illness is causing your cough and fever. And this is really what's incumbent upon prescribers to do, is to figure out, the person's depressed, but is this part of major depressive disorder, bipolar depression, schizophrenia, post-traumatic stress disorder? So that's the first order of business, is to do that differential.
Yeah, and it's interesting that there's sort of as I was looking through and as I've been exploring it, and we did a bit for our book, and but there seem to be about 4 categories that they do, sort of bipolar 1, bipolar 2, the cyclothymic, they call it, and of course the other one, which is a glorious one that we have in DSM in various places, unspecified. Meaning the other stuff that we can't really figure out. But this act of sort of separating them up, what's the benefit of that?
It's interesting. Before DSM-3 in 1980, they weren't split up. If you had recurrent depressive episodes or you had cycles of depression and mania, you were considered to have manic depressive illness. It was only in 1980 that this division was made between unipolar and bipolar disorders, as if to suggest that they're 2 separate illnesses. And the current best evidence is they're really not separate illnesses. They're all part of the same rubric of manic depressive illness that was proposed by the German psychiatrist and the father of modern descriptive psychiatry 100 years ago, Emil Kraepelin. And he said, these are all part of one illness. And in fact, part of what's not helpful about DSM is that DSM says if you don't have an episode, if you haven't had or a patient hasn't had an episode of mania or hypomania, they can't be considered to have bipolar illness or manic depressive illness. And that's a huge mistake scientifically. Why? Because the vast majority of people with bipolar disorder start off with a depressive or what's called a mixed episode, where they're depressed, but they have some symptoms of mania. So according to DSM, without a prior history of mania, you can't be considered bipolar. And yet we know that about half of people, children, adolescents, and young adults, about half who develop a severe depressive episode at that early age will go on to have a manic episode later on, especially if they have an extensive family history of mood illness. So it's DSM is not the best guide when it comes to this area.
So potentially this could be very underdiagnosed.
Yeah, the best, everyone says, oh, everyone's being called bipolar these days. And there probably is some misdiagnosis, but the best evidence we have from controlled trials is that this illness is still underdiagnosed. And anywhere between 40 and 60% of patients on an outpatient basis who have symptoms of depression, 40 to 60% of them actually have bipolar illness. This is especially true for children, adolescents, and young adults with severe suicidal depression. Why? Because the illness typically begins in late adolescence with a depressive episode. These youngsters don't have a clear-cut history of a manic or hypomanic episode. They get diagnosed with depression and put on antidepressants, often to their detriment.
Yes. Now, can we talk about that detriment aspect, which you bring out in the article which we've published?
Sure. Well, it's not well appreciated that antidepressants have been found in controlled trials. The largest, best conducted study called the STEP-BD study, completed back in 2007, U.S. federally funded, found that antidepressants added to mood stabilizers, specifically in the United States, bupropion and Wellbutrin or paroxetine, Paxil, were not more effective than mood stabilizers alone. And a recent study just published last year showed that the antidepressant citalopram was no more effective than placebo at 6 weeks and at 12 months for those with bipolar depression. The real problem comes in is that they're not only not more effective than placebo, in a subset of people with bipolar illness, they can actually cause what's called a roughening of the course of the illness. That is, everyone knows antidepressants can cause mania in bipolar people. But what's not well appreciated is that that's a relatively small percentage of people. The real problem is either they don't work or they cause increased cycling, where people actually have more episodes of depression over time if they're given an antidepressant. And in bipolar patients with so-called mixed episodes, that is where they have depression and manic symptoms mixed in, like racing thoughts and agitation, antidepressants actually make those people worse. One study showed that it increases the risk of suicide 2.5-fold in people. The use of antidepressants will increase the risk of suicide 2.5-fold in patients with mixed depressions.
Yes, and this is so interesting, Brian, and it reminds me of one of my patients, and I think it's relevant for psychotherapists to be aware that they might quite often be the talk therapy side of their client's work. So, in this example, I had a client who was being attended to by a psychiatrist and to manage the sort of mood difficulties, and had other things that were going on, and was mainly there for depression. And she came to see me, was referred to me as the talk therapist. And what I noticed was she kept talking about her depression, but the talk was very agitated and very rapid. And I started to think in things like, what am I getting? Depression and anxiety at the same time. And it was a little bit of fiddling about that anyway ended up with this realization that the depression was an incorrect sort of a diagnosis, and it was bipolar. But that was a telltale.
Yes, it's important to realize that depression, classically conceived, has less to do with mood than it does with psychomotor slowing.
Yes.
And whereas mania is psychomotor excitation. And what you're talking about with your client is someone who had symptoms of depression, but also had simultaneous symptoms of psychomotor excitation. They were talking rapidly, perhaps difficult to interrupt. They were agitated. They may have had racing thoughts that contributed to early insomnia. And these group of patients we know just don't do well on antidepressants. And as I said to you when we first got going, before we started recording, it's important for therapists to realize that we as talk therapists have a horse in this race. We can't just leave it up to the psychiatrist. Why? Because if you've got someone who's bipolar or in a mixed depressive episode, and they're on antidepressants and they're being made worse, effective psychotherapy becomes well nigh impossible. It may even be futile.
Yeah, and I just want to quickly highlight that one you brought in there, because it's exactly what my client had, was sleep issues, insomnia issues. So that's another telltale thing to be looking for.
Yeah, when we work with depressed patients, they tend to be slowed down. They tend to, the session with someone who's severely depressed in a pure depression can be very painful for them and for the therapist, because they're slow to respond. They have little to say. You have to encourage them. You have to ask questions. You have to be active. When you get someone who meets diagnostic criteria for depression, and they're chatting away to the point where you can't get a word in edgewise, or they're difficult to interrupt and they're agitated, as you thought, you have to say, wait a minute, this isn't depression. Depression is psychomotor slowing. This person is revved up.
Yeah, so some of these characteristics, and maybe you can expand on some of the characteristics that therapists need to look out for. If we're, putting the DSM aside for a moment, in clinical practice, what are the telltale signs then?
Well, it's actually important to put the DSM aside, because when you think about how do we make diagnoses with DSM, it's based on a list of symptoms primarily, almost exclusively. That is, if you have 5 of 9 symptoms of depression, you're considered to have a major depressive episode. But symptoms are only one of 4 validating criteria for a diagnosis. To make an accurate diagnosis, a therapist or psychiatrist must get beyond symptoms. Why? Because symptoms are nonspecific. Again, to go back to the physical analogy, if you have a cough, it could be from bronchitis, COPD, congestive heart failure, pneumonia, or COVID. If you have depression, it could be from depression proper, could be part of PTSD or trauma, or it could very often be a part of bipolar illness. So what should therapists look at? Maybe we can expand on this, but just to give you the broad overview, you have to look beyond symptoms to genetics, family history, and there's certain specific things beyond the obvious, a family history of bipolar illness. You have to look at the course of the illness, especially the age of the onset. For therapists working with children, adolescents, or young adults, you must keep in mind that severe depression at that age is a fairly robust marker for someone who's going to go on to have a manic episode or a bipolar course. It's not diagnostic, but it should raise your index of suspicion. So we have symptoms, family history, course of illness, and then the last category is response to antidepressants. Have they failed multiple trials of antidepressants? Have they gotten a little better, then sunk back into depression? Have they gotten more irritable or agitated on antidepressants? So the key to good diagnosis, get beyond symptoms to course, family history, and response to antidepressants.
Yeah. And because one of the things as we go through there is we're starting getting a sense of that. There's a psychotherapist we're a non-prescribing profession, and
Right.
which I think is good, because I think you need to have there's a lot to know. So, but we need to know about things. And I just wonder if you could share some of your thoughts on this balance, or this interaction, or the frameworks between the mood stabilizing medications and the other sort of medications using, and the psychotherapeutic type of interpersonal engagement. How do they work together, or what's your thoughts there?
Well, I can tell you what the research says, which should probably be more helpful than just my thoughts, although, I've been a psychotherapist in practice for 45 years. The research is pretty clear. If you have bipolar illness, the foundation of treatment really has to be a combination of mood stabilizing medications and atypical antipsychotics. We can get into some of those specifics if you like later on. Psychotherapy by itself is probably not going to be effective in stabilizing the long-term course of the illness. However, psychotherapy, certain specific forms of it, including family-focused treatment, interpersonal social rhythm therapy, dialectical behavior therapy, when effectively applied, improve the course and the outcome of treatment. They're very, very critical to long-term stability. The other thing that's interesting, that's neither medication nor psychotherapy for long-term stability, is what's called circadian rhythm integrity. Some very interesting research showing that a regular sleep-wake schedule, avoidance of bright light at night, and getting bright light during the day can be quite mood stabilizing, even in the absence of medication.
And I think that's pretty true right across, isn't it? Yeah.
Well, it is as a general part of good health to do that, but it's especially important for people with bipolar illness. And all the skills that we've developed over the years for engaging with our clients can come in very handy, even the general psychotherapeutic techniques, for helping patients accept the diagnosis and the need for medication. You have to keep in mind that bipolar illness is still highly stigmatized. You'll hear people talk all the time about, oh, that's my ADHD acting up, or I'm on this or that antidepressant. You're not going to hear anyone say, oh, that's my mania acting up. And let me tell you about the lithium I'm taking. There's still a tremendous stigma attached to this. And as therapists, especially when people come to us not for a diagnosis or treatment, you have to be very careful about introducing the concept of bipolar illness, because very often it's experienced as yet another narcissistic blow. And accepting the illness is a process of mourning. And there's a lot of work to be done between denial of the illness, which people often start with, and then acceptance. And that's where the skills of psychotherapy come in.
And I think you said it can take years to come to a diagnosis. Is that right?
Well, yeah, the research in this regard is very sobering and upsetting.
Disappointing.
Disappointing. Yeah. It can take an average of 8 to 10 years for people to get an accurate diagnosis of bipolar illness. On average, people see 3 to 4 mental health professionals, including psychiatrists, between the time of onset of their symptoms, which is typically depression, and the accurate diagnosis of bipolar illness. And during those 8 to 10 years, guess what medications tend to be used the most? Yeah. Antidepressants.
Yeah, we're kind of expectant of of depression and of anxiety. So it's and misreading. Yes, it's such a subtle. I'm just trying to find the right words, and perhaps you could help me. But this understanding of the fact that we have cyclic movements within us, that we're expressant of, we're not so simplistic as just to have a unipolar thing as our only alternative.
No, this is why you need to get beyond symptoms, but also therapists need to get beyond, and prescribers need to get beyond current symptoms. No evaluation of a depressed patient is complete until a therapist or a prescriber carefully searches for a history of hypomania as defined by periods of increased energy and productivity that often rapidly shift into these lethargic shutdown depressions. But it's amazing to me how often prescribers will simply make a diagnosis and a treatment plan based on a cross-sectional evaluation of symptoms without looking for a history of hypomania and without really doing a good family history to see if not only there's bipolar illness, but a multi-generation history of depression, mood dysregulation, explosive temperament, suicide, and that's the bad stuff. The other thing that you need to look for in a family history that's important is a family history of creativity, artistic and musical talent. Some of the most famous artists, composers, writers in Western civilization have had bipolar illness. So in the family histories of people with bipolar illness, you see a much higher rate of creativity and artistic talent than you do in the general population. That's something you need to look for as well.
Wow, that's very interesting. Yeah. Now, I've got a question. And so as a therapist working with someone with bipolar, and they're also, under a psychiatrist who is giving them a antidepressant, where do I stand then? I guess it's an ethical question in terms of informing the client, because, the psychiatrist is seen to have more authority.
Yes. Well, you're putting your finger on a real problem, Matthew, which is, I've had psychiatrists say to me, Dr. Quinn, are you a medical doctor? And I say, no, but I have read the research. And the research and the science are crystal clear. Antidepressants are not the treatment of choice for people with bipolar illness. In fact, in the United States, the American Psychiatric Association standard of practice is to avoid the use of antidepressants in patients with mild to moderate bipolar depression, and to use mood stabilizers like lithium and divalproex instead. Unfortunately, your experience is very similar to mine, and I think is very common. Antidepressants are the most commonly prescribed medication for people with bipolar illness, even well-defined, identified bipolar illness. And in 20% of cases, a recent study showed, they're prescribed in the absence of mood stabilizing medication. So what do we do? Well, all you can do is have a rational, science-based discussion with the psychiatrist and with your patient, if they're ready to hear it, about the optimal treatment and why they're stuck. It can come as a source of tremendous relief and hope to the patient who's been on multiple medications for many years and just not doing well, to hear that there's another approach that really holds the hope for acute improvement and long-term stability. So I think our job as therapists is to talk about the research. with the patient and with the psychiatrist.
Now, you talked about the circadian rhythm and, getting into, a good rhythm with the rising of the sun and the falling thereof.
Yes.
What are some of the other key elements, especially when we're talking about talk therapy, that we should be honing in on?
Well, assuming the person is appropriately medicated, let's jump past the antidepressant dilemma. Let's say they're appropriately medicated. Well, actually, if you've gotten there, you're probably halfway home. But this key concept of accepting the diagnosis and the likely need for lifelong medication is something that depressed people have a very difficult time understanding and tolerating. And our psychiatrist colleagues have neither the time nor, in my experience, the personal inclination to patiently discuss with their patients what it means to have this illness and to take medication. So that is a key issue. But another part of it that's important are emotion regulation skills, especially managing anger. And what's so common in any depressive illness is depressive and anxious rumination. It's very important for, I think, therapists to borrow some of the findings from the third wave of cognitive behavioral therapies like acceptance and commitment therapy, dialectical behavior therapy, be able to help their patients stand back from their painful, depressive, anxious ruminations and learn how to get some distance on it and to help them re-engage in life and living rather than in depressive ruminative suffering. So that's another big challenge psychotherapeutically.
Yeah, there was some very interesting public sort of general public work presented through Stephen Fry, the English actor and raconteur, showing that and interviewing and talking to various people about this capacity to manage within frameworks of medication, but in addition to that, he found that the medication system was insufficient. Working with at the moment a young couple, and one is requiring medication still in a very strong way, and she's perhaps a bit reliant, and maybe we need some work there. But interestingly, over the years, the fellow, the chap, has found that he felt he could manage better on without so much medication assistance. And so he started to talk to his psychiatrist about that and resolved, and he found that he takes now very little medication, and he utilizes sort of self-directed management of himself, and he's managing it this sort of flow and change through life, and that degree of returning and understanding some sense of independence. Is this something that is common, or is this how do people, as you say, they feel better when they're at least given a diagnosis that they can understand?
Well, some people do. Some people find it a great relief to have a label and that's accurate and that explains their suffering, and particularly their non-response to years and years of various inappropriate medications. I think you mentioned one, Richard, one of your clients who was on multiple medications. This is not uncommon, where people are given an antidepressant because they're depressed. They're given an antipsychotic because they're angry and agitated. They're given a stimulant because they're distractible and can't concentrate. They're given an anti-anxiety agent because they have panic attacks and anxiety. And people wind up on these cocktails that are, it's not even so much the cocktail that's the problem or the number. It's that it's a medication for each symptom. It's sort of like, again, like you go to your doctor with a fever and cough and aches and pains, and he sends you home with acetaminophen for the pain, Robitussin for the cough, and something else for the other symptoms. So it can come as a real relief to people to know that there's a specific illness with specific treatment. But again, you got to be careful, especially as therapists, where people come to us generally initially not for a diagnosis, but for what they consider problems in living. You got to be careful about dropping the bipolar bomb too quickly, because it can really scare people off.
Yeah, I think this is so such good advice, and I think that wonderful word careful, that cautious, that gentle type of approach, which is also one of the things that we're really advocating in the work we do. So bringing all these topics is not so that we're not trying to encourage therapists to run out and go, hey, I've done the thing on bipolar. You've all, woo. It's right. Just to embrace, to actually encourage you to be more thoughtful, even more thoughtful is what we're hoping. And we kind of, which is a lovely place to be leaving people with, but I don't want to. We're kind of getting to the end of our time. I'm just wondering if there's something important that we've missed, or if there's just a sort of a summary or a message you'd like to leave our good listeners with.
Well, I guess there would be two things which are not new. They're just a review, a recapitulation of what I said. One thing I'd really like your therapist listeners to consider is, if you take nothing else home from this, don't make the mistake of going from symptoms of depression to diagnosis of depression to a referral to a psychiatrist for antidepressants, because lots of times you're going to be wrong. Remember, 40 to 60% of especially young people with a severe depressive illness actually have a bipolar illness, not plain depression. And then the second point is, whenever your listeners get into diagnostic conundrums or debates with their colleagues, well, is this ADHD? Is it depression? Is it bipolar? Is it borderline? The way to get out of that mess is to look beyond symptoms to genetics, family history, course of illness, and response to antidepressants. You will get a lot clearer picture if you look at those diagnostic validators rather than sort of ruminate over a list of symptoms and what they could mean.
Yeah, beautiful summary. But great, Matt. That was great.
Absolutely. And for people who want to know more, we will point them to a number of books that you have. You've got a Wiley guide on bipolar, and you have another book, the Depression Sourcebook.
The Depression Sourcebook, yeah.
So we'll leave links in the show notes for people to find out more about that. And we just thank you for your wonderful work.
I very much appreciate it, fellows. Thanks so much for having me on.
All right. It's been wonderful. Thank you, Dr. Brian Quinn. And we'll look forward to hearing more from you in the future.
All right. Well, thank you, Matthew. Thank you, Richard.
Pleasure.
Take care.